Thank you everybody for attending this symposium to talk about pain. Pain on a beautiful summer night in Houston. And sometimes the pain comes from the bladder, and that's what I am going to focus on. So if any of you or any of your friends have had or experienced bladder pain, probably have come across the name of interstitial cystitis. That's the older name of this entity that we now know as bladder pain syndrome. And we're going to talk about that. So what is it? Bladder pain syndrome is a very unpleasant sensation, right? Could be pleasure, it could be pressure, it could be pain or discomfort that is perceived in the area of the bladder or the urethra, but is also associated to urinary symptoms, urgency, frequency. And we have gone through many definitions of this disease, and we have finally pointed out in the States that it has to last at least 6 weeks. In some other countries, the definitions are longer than that, but at least 6 weeks is something that we look at. And also in the absence of any other cause. Like, for example, as Dr. Nassif was talking about, fibroids can cause pain as well. So we have to make sure that there is no infection, there is no fibroids, or any other identifiable cause for the pain. Unfortunately, as you see in the picture, this is the way that many patients come to the clinic, right? They feel that there is a burning sensation in the bladder or in the urethral area, and the patients think that have a urinary tract infection. In fact, they go to the ERs, they go to multiple doctors, they get treated, and they don't get better. So they finally realize that there is something else other than that infection going on. So oftentimes the patients go to the restroom and they don't leave the restroom because every single drop of urine in the bladder causes the pain. So this obviously decreases the quality of life because of the constant pain and the amount of time that the patient has to be in the restroom, day and night. Sometimes the patients cannot even sleep. How common is this disease? Unfortunately for women, it's way more common in women. It's 5 to 1, women to men. And the prevalence in adult women is anywhere between 2 to 6 to 7%. So it's not negligible. That means that there is about 3 to almost 8 million women in the United States with this condition. Locally, now we are more aware of the diagnosis, and because typically women were maybe going to the doctors for 4 or 5 years, having hysterectomies, having different kind of treatments that did not address the issue. Now we are more in tune with this diagnosis, and we can provide earlier treatment. Unfortunately, also bladder pain overlaps with other conditions that have pain conditions like fibromyalgia, pain in the entire body, IBS, muscle pain in the pelvic floor that Sarah is going to talk to us about, anxiety and depression. What causes this disease? We don't really know, but we have some ideas. So there are different theories. The first one is that the lining of the bladder is leaky, is deficient in a layer that is the glycosaminoglycan layer, and that allows for the toxicants that are in the urine to get in contact with the nerves or the epithelium in the bladder, making it more susceptible to pain. So that's number one. And we see some evidence of that. We can see here there is, it's a little too pale, but the lining of the bladder is a little thinner than it should be. The other theory is that there could be there are some indications of a neurogenic type of inflammation. And we know that because when we do biopsies in these patients, there are some cells that come with inflammation, like mast cells, and the release of different neurotransmitters that potentiate the pain in the patients. Infection is always in the background. It could be a cause, it could be a perpetuating trigger for the symptoms, but because of the continued inflammation that the bladder is under when there is an infection of the bladder. The issue is that once we have any of these events, the pain just can become what we know as centralized. So what does that mean? That means that the pain sends some repeated signals from the bladder to the spinal cord and from the spinal cord to the brain. And then just the brain gets confused because it doesn't know where the stimulation comes, if it's coming from the uterus, the bowel, or the bladder. And then any stimulation that comes from the area gets reflected to any of the organs in the pelvis. So that was very difficult to pinpoint. And that's why probably some bladder-specific treatments do not address the pain immediately, right? Because the patient has been, as we call, centralized, or the pain has been centralized. And that's key in the formulation of a treatment plan for our patients. We know that, unfortunately, this is a chronic condition, and it's a chronic condition that is characterized by flare-ups. And some patients can really identify what is the trigger for them. So some certain foods and drinks, a UTI can trigger a prolonged flare-up of the bladder pain syndrome, stress. For some women, it's wearing tight clothing. And for other ones, it's recent sexual activity. So it is important that there is some degree of alert on the patient's part. That way, you can just bring the information to the provider, so we can help you better. A simplified slide on bladder function. You know, the urine gets produced in the kidneys, and the urine travels through the ureters to the bladder. So in normal circumstances, the bladder has a good compliance, it can distend very well, and it can accommodate a lot of urine, or a good amount of urine. Sometimes in patients with interstitial cystitis, the bladder is scarred, is inflamed, and it starts sending those signals at very low volumes to tell the patient that needs to empty the bladder, when in reality there is not really that much volume, but it's just that sensation. How do we diagnose interstitial cystitis or bladder pain syndrome? So unfortunately, there is no test that can tell us you have this. There is no a blood sample, a marker, or anything like that. No. This is a clinical picture. So we're going by symptoms and by ruling out other obvious causes of pain. Once we have done that, and how do we do that? We do that by running urine analysis, right? Urine analysis, culture to make sure that there is no an obvious infection. Sometimes, if the patient, according to the patient's age or risk factors like smoking, that puts the patient at risk for bladder cancer, we will have to do a cytology. And also, we can take a look inside the bladder, a cystoscopy. Here you can see an example of how this is done. It's a simple procedure that is performed in the office, usually under local anesthesia, and that can tell us, first of all, if there is anything else that is not interstitial cystitis, like bladder cancer or a foreign object or something like that, but also can show us the characteristics of interstitial cystitis in some patients. And I say in some patients because not all the patients are going to display abnormalities in the cystoscopy, and therefore it's not necessary for the diagnosis. But if you have a patient that is not responding to the treatment or is very symptomatic, we probably will need to do a cystoscopy. So this is what typically we see in patients with bladder pain. These little blood tree-like structures called glomerulations. And they appear once you fill the bladder up and empty it a little bit. That becomes more obvious. In addition, we can see ulcerations in the bladder. So this is a diagram of this, but this is the typical characteristic, the lack of vascularization in these ulcerations. And this is a pathognomonic finding of the disease. So it only happens in 10% of the cases, but if you have it, it's very, very telling that most likely that patient is going to have interstitial cystitis or bladder pain. So what can we do about this? It's very frustrating for the patients and also for the physicians or practitioners, because there is no cure per se. Again, it's a chronic condition that is going to relapse at some point, so we have to manage the relapses and try to make them less often. So I think patient education is number one. The patient has to know exactly what is dealing with, what the expectations are, and what the possible triggers are. Obviously, stress reduction, retraining on the bladder, and for that our physical therapists do a great job. In addition to the modification of the amount of fluids, paying attention to the amount of caffeine or sodas that we are bringing into our bodies. These are the usual suspects here in this slide, the foods to avoid. That's the most typical ones that you can find. Obviously, anything with a lot of caffeine, chocolate, tea, sodas, some cheeses, alcohol, all the good stuff. Spicy food. So the important thing is to try to pay attention to it and then go through an elimination process to try to identify which one is the one that is causing the relapse. But there are some medications for it, fortunately, right? They don't work in everybody, but they do work. And they are geared towards every one of the possible etiologies that I mentioned. So, for example, the first one is amitriptyline, right? It's a neuropathic kind of pain. They try to quiet those nerves. The second one are antihistaminics, right? Just to decrease that allergic reaction that we saw with the mast cells in the bladder. And the last one is actually the only one that is FDA approved. It's called Elmiron, FDA approved for this particular indication. And this one, it tries to replace the layer that was lost, the glycosaminoglycan layers, GAG layers in the bladder. But there are also some medications that we can apply in the bladder when the flare-ups are too intense, right? So you have patients that really cannot wait for the medication to take action, so they can come to the office and we can just put medications inside the bladder to try to calm the pain, right? So we have a mixture of analgesic medications, sometimes with the steroids, and sometimes also with heparin that is going to mimic the layer that is lost. These medications that are applied in the bladder usually require, a course of them, maybe 4, 5, 6, with the patients coming to the office. Although some patients, when they become more comfortable, they can actually do it at home, the installations. There are some other alternatives, cystoscopic procedures, where we actually distend the bladder and then empty it out. It's distended for a number of minutes, like 8 to 10 minutes, to try to create some ischemia in the bladder. That was used a lot in the past. We know now that works maybe in less than a quarter of the patients, but sometimes it's worth to try. I think one of the things that is more exciting in the treatment of bladder pain syndrome, and Sharon, if you can just go to the video and then probably hit the play right there, good, is the fulguration of the Hunner's ulcers, that when we find them actually is an aha moment, actually a happy moment, because we can treat that and we can just burn them. This is in the operating room under local anesthesia. We can actually find 90% improvement in these patients that can last up to a year or even more. So again, they are not present in all the patients, but when they are, it's something that we can actually do. In addition to it, if in refractory cases, we have tried intravesical botox injections. That is not really destined for that, but sometimes in refractory cases, as I say, you have to try different things. There is also the option of sacral nerve stimulation. This is an implant that goes a lead that goes into the back towards the spine, but this is mostly for refractory overactive bladder, but sometimes can be used for bladder pain. And last, in really desperate cases, there is surgery, meaning removing the bladder and replacing it with bowel. And this obviously is done in only certain institutions because it's a very drastic approach, but sometimes the quality of life is so altered that this is what is left.